We are AIA, Asia's leading insurer, significant, stable and constantly growing. Established in Sri Lanka in 1986, we are intricately connected to the lives of Sri Lankan people. It is that deep-rooted understanding that results in our pioneering corporate responsibility projects to help people. We are proud to have pioneered bancassurance in Sri Lanka and have partnered with some of Sri Lanka's most respected banks. Our agents, or wealth planners as we call them, are at the core of our success, and we invest in ensuring they are of the highest caliber. Being number one in MDRT in Sri Lanka is a testament to the fortitude of our wealth planners, who are dedicated to making the lives of our customers better. We are also the first company in Sri Lanka to win LIMRA International Quality Award for Growth in the world. Our employees are one of our biggest assets, and we prioritize keeping them happy, healthy, and fulfilled. Everything we do is geared at making the customer's experience with us easier, better, and long-lasting. That's why we are constantly innovating and evolving to keep up with our customers' wants, needs, and trends. At the end of it all, we just want to help people to make the most of life, to protect themselves and those they love the most, to help them live healthier, longer, better lives.
Actually, this is after COVID, we are going to have this lecture, physical lecture, for the first time, and see what a large crowd here is what is striking. Actually, these lectures we used to do before the COVID on-site, and during the COVID time, we tended to do quite a few on Zoom. But now we are recommencing the lecture once again. So we are so happy about this participation, and so I would like to introduce the lecturer, Dr. Mihiri Rubasinghe, consultant pediatric ENT Surgeon who is attached to the large unit, and then is going to talk about the common ENT problems in children. Over to you.
Thank you, Saranga. I'm quite happy to be here. I'm thankful to the organizers as well as the sponsors. I would be boring initially to see all the chairs, but right now we are good the participation, so we start. I would like to talk about some common ENT problems in children. So why we are talking about this today is we would like to cover the following areas in our lecture. The importance of having a clear idea about the ear, nose and throat diseases in children, because we are dealing with children here in this hospital as primary, secondary and tertiary care doctors. So once you go from here, you might go and join a secondary care institution. Right now we are in a tertiary institution. Also in your private practice, you are a primary care physician. So in all sectors, this knowledge would be helpful. That is my thinking. And also how that knowledge is going to be useful to understand a variety of diseases and conditions in children presenting to general pediatrics, especially on the medical side, and also our subspecialties. And also it is very important to know when to refer to us, when to refer to ENT, when to refer as an urgent case, or when to refer to ENT clinic as cold cases. So we start now. So before going to all the details, I would like to just recapture your memory about your ENT examination, which you did long time ago, maybe some of you all. of history taking, examination, quick examination, and some important investigations in ENT, very few investigations actually, and also some basic ENT instruments that you might need as a general practitioner. So, in the history taking, it's very important to take a very concise history, very targeted history, and so you need to take relevant, quick history, and when you ask questions, you always ask close-ended questions, otherwise you will never get into the point. So just ask whether this condition is there or not, rather than letting the child or the mother to speak about the condition. So in this way, you can come into the diagnosis pretty quickly. So as an example, if a child is coming with an ear ailment, as you know, you need to ask for the duration, the severity, and associated other things like ear discharge, and also whether there had been a hearing loss in a bigger child. You can ask the child whether there had been any hearing loss, or with a toddler, you can ask whether there had been anybody has noticed about hearing loss in the daycare center, or in school, or even at home. And tinnitus, of course, child might be able to take tinnitus when the child is a little bit bigger. Vertigo is a symptom that most of the time that we observe in a smaller child, but in an older child, the older child might come up and say about few features of vertigo, where we come to the conclusion that it is vertigo, since vertigo is just a symptom rather than a disease. And also if there is any nerve palsy, especially the cranial nerve palsy, seventh nerve palsy, which is very important in ENT, especially in ear cases, so that also we might be able to ask few questions. So this is history taking in a child who is coming with ear ailment. And also if a child is coming with nasal ailment, you need to ask about blocked nose. We already child we see blocked noses, whether it's unilateral or bilateral. And sometimes the blockage changes from time to time. Maybe in the morning one side is blocked, then towards the evening maybe the other side is blocked, and some days there is no blockage, some days both sides are blocked. So you need to ask those things. And about anosmia and hyposmia, the sense of smell sensation that you have to ask directly in a bigger child, from a bigger child. And if there is any associated nasal bleeding, whether it's fresh bleeding or old blood, or whether there is blood stained nasal discharge, blood stained throat discharge, which is again coming from the back of the nose, you need to ask them. And if there is any watery nasal discharge, especially after a head injury, then you have to suspect CSF. Things like nasal itching, sneezing, you need to ask these questions. And if there is any pain in the nose, also widening of the nasal bridge, the anatomy is changing gradually, then you have to suspect that something is going inside the nose. So that is also again you need to ask. And if there is any change in skin color over the nose, because there is an inflammation spreading like cellulitis, or history of recent trauma to the nose, and also if there had been any previous nasal surgeries. Throat ailments, few things you need to ask. Whether there had been any dysphagia, that is painful swallowing or difficulty in swallowing, there are two different things. And whether there is any fever associated with the throat ailment, whether there had been any change in voice, hot potato voice, is something that you get, and there is a lesion inside the mouth, like a peritonsillar abscess or a large tonsil, or sometimes even epiglottitis. Hoarseness is something that you get because of the involvement of the vocal cord at a slightly lower level. So there are two types of different types you need to ask clearly. And whether there is a difficulty in breathing, it could be stertor, which is just snoring, simple snoring, or the stridor, which is due to the upper airway obstruction at a lower level. So you have to imitate these noises to the patient and ask whether the patient, the baby, you need to ask the mother whether the baby had this sort of a noise at any time. And also whether there is mouth breathing, apneic episodes, snoring, and whether the child's sleep is okay at night. If the child is having a very restless sleep, then you have to come into conclusion that the child is having some sort of upper airway obstruction. And at the same time, if you have got any neck lumps, whether you think that they are lymph nodes and the duration, and the lymph nodes or the lumps are getting bigger, and acute onset of lumps, also you got these two things. When the child comes with a throat ailment. Again, the basic ENT examination, I just want you to know a few things about basic ENT examination. You need a good light and you need a good support from another person, maybe a nurse or an attendant, to examine a child for ENT. So, your good light may be just daylight or a headlight. And the positioning of the child, this is how we do ENT examination. And we can restrain the child, especially when you want to examine the nose or if you want to take a foreign body out from the nose or the ear. So the first picture shows that we call it mummifying. We take a bed sheet or some sort of a sheet and wrap the baby from neck downwards and hold it very tightly and get the mother to hold the child in that position. So in that way, there is very less disturbance of the child as a mother, and at the same time you have to explain to the mother that she needs to keep the baby in this position, otherwise it's going to be quite difficult for us to examine. And also you need few essential ENT equipment like a tongue depressor or otoscope, that's the ear torch, or few specula attached to the ear torch. And if you're assessing hearing, you need a tuning fork, basically 520 Hz. And it's good if you have a sucker machine with nozzles and few instruments to remove ear and nose and throat foreign, especially ear and throat foreign bodies. So I like to show this picture. It's basic ENT things that you might need even in your general practice. First one is the tongue depressor. It's ideal to have a metal tongue depressor rather than a wooden tongue depressor, because in a bigger child the wooden one might break inside. So it's always good to invest on a proper metal tongue depressor. The other one is a crocodile faucet where we used to take foreign body out from the nose, and the other one is suction nozzle. If you have got a sucker machine, you can connect that and clear the nose before you see, because sometimes with the nose, with the secretion, we might not be able to see certain foreign bodies and certain pathologies. Few other things which we need to take foreign bodies and wax out, and also the otoscope with the specula with a good light. So these are very few things that you need to do a good ENT examination, which you can do even as a private physician. And this is how we hold the instruments. First picture shows the examination of the ear in the correct position, where you use the otoscope to examine the left ear, holding the RX in your own left ear, and that is you pull the ear upwards and backwards with your right ear and examine the ear canal. And when you are selecting the specula, you have to use the biggest specula possible. So in that way, you can examine your external ear canal, as well as, if you are lucky enough, sometimes the tympanic membrane. So nasal examination, the initial one, without causing any distress to child, you can just hold your metal nasal speculum under the nose and ask the child to close the mouth and breathe in and out gently. So in this way, you will know whether the nose is blocked or whether one side is blocked or both sides are blocked. So a lot of children coming to us with adenoid hypertrophy, there is hardly any nasal passage, nasal airway. So instantly we will know that their nose is blocked, and the most likely cause is adenoid. And if you want to examine the throat for tonsils, it's ideal to use two tongue depressors on either side, and then ask the patient to open the mouth and pull the tongue out. Because they hate to have tongue depressors really on the tongue, because you get that everybody gets to see a very bad reflux, and this is very quite easy to use the tongue depressors on the buccal surfaces rather than on the tongue. So this is how you examine the throat, ear, nose and throat, or basic ENT examination. There are very few investigations which we need to come into conclusions in ENT. If you see pus anemia, we take a swab, especially from the nose or any other head and septic sites, whole blood count and CRP, and hearing assessment. These are very few things that we need to come into conclusion in ENT. You don't need a lot of fine things. So initially, the very first one I would like to discuss about is the nasal obstruction in children. So this also, according to the age, it can change. The commonest cause for nasal obstruction in babies is what we call the rhinitis of the newborn, which is sort of an inflammatory cause. But if you are suspecting any body abnormality or any other congenital abnormality, the situation would be different. So any baby born And if there is cyanosis at birth, which is relieved by crying, then we have to suspect that there is a blockage in the nose, right? Because babies are obligatory nasal breathers, when they can't breathe through the nose, they become cyanose, and when they cry, the mouth is inadvertently open, and then they breathe through the mouth, and the cyanosis is relieved. So cyanosis, which is relieved by crying, baby becoming pink on crying. So we are quite sure that there is a congenital problem in the nose in these babies. If it is bilateral, it's actually an ENT emergency because the baby cannot breathe at all. But if it is unilateral, most of the time it is missed until the child is a little bit grown. But if somebody passes an NG tube size 5 10 stage on either side, initially you might know. But other than the corneal atresia, which is the commonest cause and which is very important to diagnose, if the baby becomes blue and which is relieved by crying, is a corneal stenosis and corneal atresia. They both present with significant respiratory distress at birth. So why are the babies called that? The babies are being called that they are obligatory nasal breathers until about 3 months because of their anatomy. Because their larynx is at a very high level and larynx is directly open to the back passage of the nose rather than the oral cavity, and the epiglottis is just directly towards the back of the nose, towards the postnasal space. So once they open the mouth, and also their tongue is properly sealed, tongue is touching the hard palate. So tongue is quite sealed unless they are sucking. So they can't breathe through the mouth and they have to breathe through the nostril, and if the nostrils are blocked, they become cyanose. They just can't open their mouth and breathe because of this anatomy. But as the child grows, the larynx goes down in position and becomes elderly position in the early teenage. But until then, after about 3 months' time, they are not really obligatory nasal breathers. So once in a tertiary care center, if you get a referral that the baby is born and the baby is cyanose and is relieved by crying, the number one thing is to exclude corneal atresia or any other nasal blockage, anatomical blockage. We had to pass a size 5 page nasal catheter on bilateral sides. Maybe both sides you could pass, but maybe with difficulty. So other than corneal atresia, there are a few other conditions which are not very common. Corneal atresia is the most famous one, which we call the nasal piriform affected stenosis, where the obstruction is quite anterior. And there is another condition called mid-nasal stenosis, where the obstruction is little bit in the midway. But the choana is really at the back of the nose. So at the back passage, the bony passage of the nose, if the choana is blocked, it's really at the back of the nose, and still you might be able to pass a nasal catheter up to some distance. Right? And then it becomes coiled and it comes back. So other than this, other than corneal atresia or corneal stenosis or mid-nasal stenosis or piriform affected stenosis, there are a few other conditions that can cause nasal blockage in a newborn, like the soft tissue masses, nasal gliomas or encephalomyces which has descended down, or sometimes nasal actival duct cyst can give you a similar picture if cyanosis is relieved by a cry. So the second one is when the child is a little bit bigger, in the toddler stage, the commonest cause of nasal obstruction is adenotonsillar hypertrophy. Adenotonsillar hypertrophy occurs in toddlers. Sometimes even in late, say maybe after 10 months also you can still have adenotonsillar hypertrophy, but it's commonly found in toddlers. As you know, adenoid and tonsils are both lymphatic tissues belonging to the wall diastole, so encircling the upper aerodigestive tract. And in a child, the postnasal space is quite small and the adenoids are quite big. So the relative size change, there is huge obstruction. And they usually present with snoring. There is a lot of noise during sleep, and during sleep they are quite restless and they keep their mouth open. Even sometimes during daytime their mouth is open and they breathe through their nostrils, and there will be persistent nasal discharge all the time. And their appetite is poor, their behavior sometimes can be changed, and they don't gain weight properly. So for adenotonsillar hypertrophy, the first line management is medical. So what we do is we give steroid nasal drops or sprays, and also we give nasal douche. If there's not of nasal discharge produced by these adenoids, more than the real size of the adenoid, the nasal blockage is due to the persistent nasal discharge. So we give nasal douching, so we teach the children, teach the parents how to douche their children known with a special solution which they can make at home with saline, with table salt and some sodium bicarbonate. So thick secretion will be washed away and they will be relieved. This is basically we have to do before we put the drops or the spray. So when you prescribe drops, you have to ask the child not to swallow it. If it's a bigger child, the child can taste the drops in the mouth because the drops are put in a supine position. Invariably, the drops will come from the nose to the throat. So they will start tasting the medication, and once you start tasting, you have to ask the child to get up and spit it out into a bowl rather than swallowing. Otherwise, you can get steroid overload and problems, cushingoid features in children who are on long-term nasal drops. If you are giving a nasal spray, again, it's very important to say, once the mother sprays the nose, and they are usually the mothers ask the babies or children to snip up and get it into the throat, which is again bad. Right? Again, it will go to the throat, and also at the same time, it will not work in the nose. So once we put the sprays, ask them not to snip up. Just leave it in the nose. That is where it's going to work. And also, we usually give antihistamines. This medication, medical management is for 3 months. If they are not relieved after 3 months, then we have to seriously think about whether they need any surgery. So before we contemplate on surgery, we get a sleep study done, which we do in our unit. So they come to the ward, usually they get admitted in the late evening, and they sleep in our ward, and our nurses will do a mini sleep study where they check blood pressure, respiratory rate, snoring, apneic episodes, and saturation hourly until morning. And also we have a machine called level 3 sleep study. On the first picture, there's a small box-like thing fixed to the chest, and that reads all these findings, and in the morning we can put it to the computer and get a recording. So sleep studies will show that the child has significant oxygen saturation drop during the night, which we don't like. And if that is the case, we have to report to the respiratory physician. And anyway, in children, adenotonsil hypertrophy is the number one cause of obstructive sleep apnea, and they have to have the adenoids and tonsil out. So that is a surgery done under general anesthetic. There are a few risks we always explain to the parents about blood loss, because adenoids and tonsils are quite vascular structure. We hardly have to give blood, but still we preserve blood. And there is significant post-operative pain. That also we have to tell. If the child is an older child, we always tell them about the pain after the following day morning. Quite severe. We had to give analgesics and manage. And once at home also, they had to take about 2 weeks off from school after any adenotonsillar surgery, because we don't want secondary bleeding due to infections. Adenoids can grow back because adenoidectomy is done as a blind procedure, and there is no capsule as such, so we can't exactly remove 100% of the tissue. There is a chance that it can go back, but tonsils usually we take it out with the capsule and it hardly grows back. So the time-tested method of doing tonsillectomy and adenoidectomy is by doing cold steel, that is using instrument. But nowadays there are other ways like coagulation and laser, which we can do, but they are quite expensive. And sometimes the cold steel is a time-tested way. Very rarely you get complications if you do, if you adhere to the correct techniques. Other conditions of nasal obstruction are inferior turbinate hypertrophy. When you examine the nose on either side, you can see a bulge. Most of the people, they mistake it for polyps. Right? Polyps hardly occur in children, so if you diagnose polyps, if they get a referral from a GP saying this child has nasal polyps, most unlikely for the patient to have polyps. They always have this condition called inferior turbinate hypertrophy. Okay, the turbinates on either side of the nose, on the lateral wall, especially the inferior one, as in the top picture. Inferior one can get hypertrophy due to allergies. So that also can change us from time to time. And once it is hypertrophic, it appears like a huge lump on the side of the nose, which a lot of people mistake for polyps. So that is some adenoid hypertrophy on the left hand side. On the right hand side, we can see actual polyp, which is quite inside, and the color is completely different. It is of a very pale greyish color you get in the proper polyps, but they are quite unlikely to have in children. So adenoids, the inferior turbinate hypertrophy or adenoid sometimes, or even the polyps can give rise to severe nasal obstruction and sometimes completely blocks the nose. Again, the same medication is applied, steroid nasal drops or sprays for about a month's time, and then we review and give for maximum of 3 months time. If it is not working, they have to go for surgery. For turbinate hypertrophy, we do a surgery called turbinate reduction surgery, and also sometimes we can cauterize the turbinate, but most of the time they grow back, and we had put them on steroid nasal topical steroid for some time. In addition to that, the lower picture shows a condition called septal deviation. That's the wall in between the two nostrils is gone to one side, which is a nasal septum, which is made up. Anterior part is made of cartilage, the posterior and the inferior part is made of bone. So the deviation could be due to congenital problem, or it could be due to acquired due to blunt nasal trauma. So if there is very significant nasal blockage due to septal deviations and the patient both nostrils are completely blocked, we have to do surgery, but we prefer to wait until the child is 15 years old, until the nasal bone structure is completely completed at that age, so we can decide exact surgery to be done. Otherwise, once we do surgery before 15, because of the nasal growth, this deviation sometimes can get worse. So we prefer to wait unless they have complete nasal obstruction and the parents or the child insists us to do surgery. We don't want to do nasal structural surgery until they are 15 years of age. Nasal polyps, as I told you, is quite unlikely in children, but if you see a nasal polyp only on one side, it is a condition called anthropoidal polyp, which is again not very uncommon in children, where the polyp arises from the maxillary antrum and grows into the nose and also grows into the choanoids. Where we give one, and it is just a single polyp. So you see that as a unilateral nasal polyp. But if you see bilateral nasal polyps, if they are really polyps, then you have to exclude a condition called cystic fibrosis, which is a condition where you get proper nasal polyps or ethmoid polyp. Very rare in children, you can get nasal growths mimicking nasal polyps, but they are malignancies like in sarcomas. Again, a hot topic in children, Epistaxis or nosebleed. Nosebleed is very common in children. Usually it's a self-limiting condition, unlikely in adults. Adults, nosebleed sometimes can kill elderly patients, but in children it's a very small, like a very insignificant thing, but it can happen because of violent nasal blowing while trying to clean the nasal secretions, or even after upper respiratory tract infection, or due to nose picking or putting things in the nose. So can rupture small blood vessels in the anterior part of the nose or the visuals area, and then this bleeding is self-limiting, just stops. Unless the child has had a nasal trauma, where the bleeding could be quite significant, and we may have to, very rarely, we may have to pat the nose just like in adults. So if you see a nosebleed, and it's good idea to do some basic blood tests like blood count or basic clotting test. And if they are all normal, then of course it's just a simple nosebleed. And if you see a hypertrophic blood vessels or the bleeding point, what we do is we cauterize the area with silver nitrate. We get commercially available sticks, as well as we make them in the ward, small equal wrapped in cotton wool, and we exactly cauterize around the bleeding vessel, and then in the middle, then we come to the middle of it at the end. So this usually works. If it doesn't work, we can repeat the procedure and we apply a little bit of fusilin application for about a week's time. and we ask them refrain from nose blowing and putting things in the nose. And of course, having any hot beverages or having hot baths or being under the hot sun for few days just after an acute nose bleed. This condition is called juvenile angiofibroma. It's a quite rare condition where you get severe significant nosebleeds only in males. It happens only in boys during their teenage times, 9 to 15 or so. It's severe nosebleeds, sometimes it can feel that much of bleeding. It is due to a condition called angiomatous growth called juvenile angiofibroma, where you get angiomatous and fibrous components in the tumor, which is a benign thing again, although it bleeds so much, and this is blood supplied by a significant big blood supply arterial branch of the maxillary artery at the back passage of the nose. So once this is diagnosed, this is usually diagnosed by contrast enhanced CT scan. It has to be embolized and it has to be surgically removed. So even after surgical removal, if even a tiny bit is left, they can recover. So this is a condition that can occur only in boys during this age group and which can cause life-threatening nosebleed. When we come to injuries and infections in the ENT, in the ear, as we know, the commonest cause for ear injuries, external injuries, is self-inflicting or putting things in the ear. Commonest culprit is a cotton bud or any other sharp object, whatever found. This can always injure the outer ear and it can sometimes up to the middle ear and sometimes even go beyond that, can cause the dislocation of the ossicular chain. So they present with acute ear pain or ear bleeding, loss of hearing. Sometimes the ear injuries can happen after head injuries due to fracture of the temporal bone, which contains the inner ear and the middle ear. So these fractures again are usually after a high impact injuries, longitudinal or transverse fractures. In addition to the ear bleeding and loss of hearing, they can give rise to other things like acute vertigo or even facial nerve weakness, because facial nerve also travels in the middle ear. The certain other blunt traumas of the ear also can give rise to problems like sports injuries or boxing or road traffic accidents or after domestic violence or child abuse, or sometimes it could be most of the time self-inflicted after putting things in the ear. So the first picture shows a picture of an eardrum which is bluish in color. Usually eardrums are very opaque in color. Of this type has a blood behind the eardrum, is in the middle ear. This blood is a little bit oval, that's why the color is bluish. So it's called hemotympanum, usually after head injury, after fracture to the temporal bone. And the other one shows the simple ear perforation, which is a new perforation, that's why the edges are ragged. So it is an oval perforation, usually the edges are nicely round or oval shape. This one, the ragged edges show that the perforation is quite fresh. So the two types of temporal bone fractures, which we call the transverse and the longitudinal fractures, they are serious head injuries and they can give rise to permanent hearing loss and permanent facial nerve palsy if the nerve is completely severe. So this child is having left-sided facial, low motor neuron facial nerve palsy, probably after injury to the temporal bone. Also, in addition to all these things, the CSF can leak out. So CSF coming from the ear is CSF otorrhea, and if that happens during the CT scan, and also antibiotics, IV antibiotics to prevent meningitis happening, because the same way the germs can go in, bacteria can go in. And once the ear is relatively dry, we do a hearing assessment and see what sort of a hearing damage has been done. So it's very important to assess the hearing formally, especially in a medical legal case, because you never know when you will be called to the courts to give evidence. So you have to make sure that you do a proper examination, write down your findings and send for a proper hearing assessment in all of these cases with injuries. So that is a ear injury. Next we will talk about injuries to the nose and the facial skeleton. So you know the nasal bone is the commonest bone to fracture because of this awkward position, right? So they can come with deformity and nasal bleeding. Just after nasal broken nasal bridge, there will be lot of swelling in the nose. And once you see a child just after an injury, maybe 1 hour after the injury, you really don't know whether the deformity is because of the swelling or because of the fracture. So initially we examine the child and see that there are certain things that we have to attend immediately, like there is CSF, rhinary or CSF leaking from the nose, that has to be dealt immediately. Or if there is a condition called septal hematoma, where the nasal septum on either side you see a bulge, which has to be drained as soon as possible. So other than these things, we always see these patients about weeks time in our clinic, and then we assess when the swelling goes down. We always ask the mothers, parents to bring a older photo, so we can always compare the nose before the injury and after the injury. Right? Because all the nasal bone fractures do not need treatment unless there is a significant deformity. We can just leave it like that, let the bones to settle that way. So if there is significant bleeding, like after head injury, we have to keep the bleeding, which sometimes it cracks. So once we see after weeks time, we will know what to do. But you cannot see the patient after 1 month's time. You have to see within 2 weeks time, because otherwise all these fractured bones will start forming in the wrong way. So the manipulation has to be done. The golden period is ideally 1 week, maximum 2 weeks. So this can be corrected even in the outpatient department. As with digital pressure alone, put the patient on a bed and put the firm pressure on the deviated side, and sometimes it clicks back to the center. Can give rise a little bit of play, sometimes a little bit of bleeding also, but that's a very cheap and very convenient one. You don't have to take them to the theatre. But if the damage is significant and the deformity is quite severe, then of course they need under anesthesia manipulation of the nasal bone. And once manipulated like in that position, we use certain instruments in the nose and try to bring them to the midline. We have to stabilize inside with the packs and outside also. Sometimes it splits. So that has to be there for about, springs will be there for about a week's time. And once the nasal bone manipulation is done, we ask them to refrain from any sports activity, conduct sports activity for about a month's time, or the bones will settle in the correct position. So again, if you see CSF rhinary, just like in this picture, get watery nasal discharge with the patient leans forward, and also if the patient is lying on the bed, they get a salty discharge, continuous salty discharge from the back of the throat. Particularly, you have to ask for salty taste in this salty taste unless blown, otherwise it's CSF. So, if this happens after significant facial deformity and head injury, we need ICU admission. Sometimes if you're transferring a patient from peripheral, you need intubation and nasal packings and surgical input. Most of these CSF leaks stop spontaneously with conservative management. So what we ask them, the child to never to lie supine, always to be about 30 degrees angle head up, and not to sneeze, not to strain. We give some lactulose. If there's cough, we treat that. Always give IV antibiotics to prevent when that is happening. In lot of situations, this spontaneously heals. So if it doesn't heal, then of course we need further investigation and correction. If it is done through the nose, the ENT surgeon does, or if it is defect is paralytic, the neurosurgical correction has to be done. Neck injuries is quite rare in children. You can have sharp cuts or strangulations or throttling. So you will see a bruise mark or a skin mark and bruising. Once if you see surgical emphysema, if you just palpate the neck after neck injury in a child or even in an adult, if you palpate surgical emphysema, that means a certain air containing structure is damaged. So it has to be either the esophagus or the trachea. So that is quite serious, and sometimes they come with hoarse voice and stridor also. Needs to assess the airway in a proper way under GA sometimes. And if it is in the wall, if we want to assess the vocal cord, we do fiber-optic laryngoscopy or FOL. That is done in a seated position and awake patient. So the patient is supposed to phonate, and we can compare the vocal cord to see whether there is mobility problem on one or both sides. But if you are suspecting the esophageal rupture because of the neck injury, then you need CT scan. And also rarely, if the trachea is damaged, we need a tracheostomy. So these injuries are quite rare unless the child is after a severe road traffic accident in children. So other than that, what are the other common ENT infections? You see them as medical in the medical practice, in general medical practice, in pediatric setup. The commonest is acute otitis media. Acute otitis media is a condition which is of a viral origin. So then becomes bacterial later on. Commonly seen in toddlers and younger children. Typically they present with an upper respiratory tract infection about 2 weeks prior to their presentation. They get better and then they come with an earache and then the fever comes back. Child becomes unwell, refuses to feed and cries and pulls the ear, bangs the ear. And when the ear examination, the otoscope is done, initially you will see just the erythematous eardrum, just like in the first picture. There are some blood vessels along the hand-bug barriers, and later the drum becomes very erythematous and it ruptures and then the pus comes out. So at this stage there will be significant pain for the child. Usually the initial uncomplicated viral acute otitis media are self-limiting. You need only supportive treatment, you don't need antibiotics. But if the child is less than 2 years old and child has other comorbidities, then you need antibiotics. So drug of choice what we do is oral amoxicillin or co-amoxiclav. There is any penicillin allergy, go for clarithromycin. Lot of analgesia is necessary, lot of supportive care is necessary for pain. And you have to always look out for complications. Most drops are given to relieve the eustachian tube blockage. Rarely complications can happen, not that rarely can happen. Like in mastoiditis is a common complication we get after acute otitis media in children. So in that case of mastoiditis, you get a picture like that. There's a swelling behind the ear, and the skin becomes very erythematous and swollen, and the ear pinna is also a little bit angled forward. Child is very unwell, refuses to eat and drink, fever is spiky, CRP is quite high, and the only way to know that this is mastoiditis or any other lymph node suppuration is by doing a CT scan. So that will show in the mastoid cavity there will be coalescence. That means all the mastoid hair cells have come in together and there is subperiosteal collection. Infection has spread beyond the mastoid. Now it is just underneath the skin. So this needs to be drained and given IV antibiotics. And later on, sometimes needs mastoidectomy to clear all the disease cells. So commonest one is acute otitis media, but the second one is acute otitis externa. Again, it's a very common and very painful condition where the outer infection is mostly due to the things they are put from outside, like in cotton buds or any other after certain procedures or even syringing. You can have an otitis externa like that, where you see debris, yellowish, sometimes whitish, sometimes blackish spores, fungus, both are there. Canal is very, very edematous and you cannot see the eardrum, and the child refuses to show because it's very painful to touch. So there will be tracheal tendons. When you touch from outside, when you touch over the tracheus, there will be significant pain. But this eardrum is intact. If you are lucky to see the eardrum is supposed to be intact. So the treatment for acute otitis externa is topical ear drops. The ear drops are to put to the ear, but if the child is systemically unwell, we give either oral or IV antibiotics. We always take a swab before we start treating, so we will know what we are dealing with. And once the otitis media, the perforation or otitis externa is healed, we always give them instructions on how to care for the ear with water. So water is something which is known completely for about months time, because we don't want, if the water gets into the ear, infection can come back, especially fungal infection. So they have to take precautions, drying precautions. The cheapest one is by using a big ball of cotton wool with plenty of Vaseline or petroleum jelly applied right round and putting sealing the ear. So that is the cheapest one. We give Vaseline from the hospital, they have to buy the cotton from outside, or else they have, if it's a chronic condition, we get them to buy a silicone ear plug, which they can wear for about 6 months time continuously, and they are all reusable. So how do you differentiate acute otitis media or otitis externa discharge? Quite simple. Acute otitis media, the ear discharge is very purulent, like very thick, like mucoid. In otitis externa, it is usually black stain or with feces. And there will be smell in otitis externa, but there won't be any smell in acute otitis media discharge. So there will be a lot of itching and sometimes blood stain in otitis externa, but in otitis media, unless the gum is perforated just right before you examine, there won't be any blood. It's just a mucoid discharge. So it's very important to know, just by looking at the ear, they are dealing with otitis media or otitis externa. Sometimes, very rarely, both these conditions can coexist because of the otitis media irritation. You can have otitis externa. So, first thing is otitis media, because of the chronic irritation of the ear discharge, the ear canal lining has become inflamed and they end up with otitis externa as well. But otherwise, those two conditions are quite easily differentiated by examination and just a very brief history. Inner ear infections, compared to the middle ear infections and the outer ear infections, inner ear infections are quite rare. So the most serious ones are vestibular neuronitis or labyrinthitis. Labyrinthitis is whole of the inner ear is infected with viral or bacterial or sometimes tuberculosis. So in vestibular neuronitis, it is the semicircular canals and the utricals. Usually if there is an infection is viral in children, they can have a hearing problem in labyrinthitis because cochlea is also involved. They come with severe vertigo, sometimes it's tinnitus. You always have to assess the hearing in these children. So the treatment is mostly supportive, bed rest, because sometimes during the acute phase they cannot get up from the bed. They are so vertiginous, even with the slightest head movement, they can have a significant nausea, vomiting. And initially we give vestibular sedatives like fluorophoracid and sinusine, but later on those things are very light. For a very short duration you have to give, otherwise you can increase the duration of their healing. So beta histidine is something that we give maybe for months, that is just to increase the inner ear blood supply, so their recovery will be fast. And once they come out of the acute stage, sometimes they can have some vertigo on long-term basis. So for that, we give in bigger children, we give vestibular exercises and some rehabilitation that actually works. Throat infections, tonsils and pharynx. Tonsillitis is quite common in our setup. Usually it's due to organisms coming from the oral cavity. They come with sore throat, dysphagia, and they cannot sometimes swallow saliva, and they are pain and they are quite unwell. So if tonsillitis is not treated properly, the infections can spread behind the tonsil and cause peritonsillitis or quinsy. It is again quite common in teenage children, not in very young children. So they again come with hot potato voice, unable to open their mouth, unable to eat and drink. So once the tongue depressor examination is done, one can see only on one side there will be bulging of the soft palate rather than the tonsil, because soft palate is covering the tonsil on that side. So these abscesses have to be drained in the ward, sometimes under GA, and they have to be on antibiotics for about a week's time. So after the quinsy, we tend to get the tonsils out as an elective case, because always the second time quinsy is quite difficult rather than from the first time quinsy, and once the quinsy happens, it tends to happen again and again. So it's better to listen for tonsillectomy maybe after about 4 weeks time. In other children who get recurrent tonsillitis, our indications, if they have 6 episodes for about a year, for about 2 years time, then we listen for tonsillectomy. Pharyngitis, in addition to tonsillitis, in some children it's not the tonsil but the whole throat is inflamed. If pharyngitis is untreated or tonsillitis is untreated, they can end up with neck abscesses. So usually pharyngitis is viral initially, then bacterial. Very rarely it can be candida also, it can be fungal in an immunocompromised type. The child is being exposed to allergies like cigarette smoke or air pollution. Again, they can have chronic pharyngitis or the condition called laryngopharyngeal reflux, or simply what we call the GORT. The throat component of GORT is called laryngopharyngeal reflux. The acid comes from the stomach all the way up to the pharynx and burns the mucosa. So that also can give rise to chronic pharyngitis and laryngitis in children as well as in adults. So that has to be diagnosed and treated. Laryngitis is not very common in children because they quite common in adults but not very common in children. They have hoarse voice or they have difficulty swallowing also. Again, laryngopharyngeal reflux is one of the contributing factors. Where the vocal cords, when you examine the fiber optic laryngoscope, the vocal cords are quite swollen and reddish. Epiglottitis is a typical that everybody should know, everybody in the pediatric setup should know about epiglottitis, which is again an ENT emergency, occurs in toddlers and in children up to about 2 to 8 years time. It's quite rare because of hip vaccination, but in adults again you can get, even in children you can still get even after hip vaccination. They come in after respiratory tract infection, acute onset of odynophagia, drooling, fever, and then the stridor happens quite later. So they are not able to swallow their own saliva. You see the pictures on the top, on the left hand side you will see the normal larynx and the epiglottis, that's the shape of the epiglottis you see from the top. And this is the one after with acute epiglottitis, where the epiglottis is quite swollen, it appears like a big cherry or just like a lobigadian. So you don't want try to examine these larynxes in the ward. Right, but you see this picture is taken from a fiber optic laryngoscope, it is taken from the above through the nose. Right? So that we don't go and disturb these children trying to examine the throat, because all of a sudden this even tiny space can close up and they can go into acute respiratory tract, and it's quite difficult to intubate these children also. So we try to manage the airway, we try not to do intubation, but if it is really direly necessary we have to intubate. We hardly do tracheostomy for these patients, we always try to intubate and settle. Very rarely you might have to do tracheostomy if the anesthetists can't get a tube beat. Parapharyngeal and retropharyngeal abscesses are also quite common. As you see, there are a lot of lymph nodes in the upper air digestive tract. So if a lymph node is saturated in any of these spaces, they can collect pus in those spaces and later becomes a significant abscess which is threatening the airway. So they are also present with the recent upper respiratory tract infection and unable to swallow saliva, dysphagia. In addition to the previous one, they have problem with the neck. So they are swelling is seen on the side of the neck and they hold the neck in a very awkward position, in a torticollis position. These children had to be investigated. The number one is ultrasound, but if you are not sure, they have to go for a CT scan. Then it has to be either drained from inside or from outside. So this is a picture of a retropharyngeal child with a retropharyngeal abscess. As you can see, there is a bulge just anterior to the cervical spine, that the space is quite widened and there is a lot of inflammation going on. Sometimes in the later stage you can see a fluid line also, there is a lot of collection in the abscess. So these have to be drained usually from inside, from the throat under general anesthetic. They can be ENT emergencies because of the airway. In the case of nasal infections, the last one, you know, the outer nose, the skin can get infected because of cellulitis. Usually nasal vestibulitis, that is the bone, that is the hair containing part of the nose, the very anterior part, because of the inflammation of the follicles. Nasal vestibulitis can occur. These children usually come with increased crusting and tenderness, and repeatedly they are usually nose pickers, habitually nose pickers. So they can introduce infections into the soft tissue in the skin, and they can present with inflammation and nasal vestibulitis, as well as it can spread to the face and the nose. The number one causative organism is Staph aureus or sometimes MRSA. You always take a swab for the bacterial culture. Initial oral antibiotics to cover Staph is started, but if it is MRSA, we go for clindamycin, either oral or IV. And mupirocin or fusilin application over the nasal vestibule and on the nose. And once the infection is settled, to prevent the child from continuous nose picking, we ask the mother to apply a little bit of petroleum jelly or Vaseline into the anterior ears on regular basis. So they don't have to pick the nose all the time, and that will prevent organisms being introduced to the nose. Sinusitis is again not a very common thing, but it can happen in all the children, usually secondary to upper respiratory tract infection. Sometimes they can be associated with nasal polyps, like in the case of cystic fibrosis. Could be allergic also, sinusitis. Very rarely during COVID and all, it could be fungal. We always thought about fungal nasal infection during that time. The sinusitis is not resolving with oral antibiotics. They have to be CT scanned, and also nose has to be examined with a telescope. And in that picture, you can see some pus underneath the middle terminate. So we take a swab from the pus and give it the appropriate antibiotic. And long-term antibiotics or antifungals, it is fungal. And in the end, as a surgical option is functional endoscopic sinus surgery, which we commonly call FES. Where all the disease sinuses are taken out. We try to preserve the nasal anatomy by doing very limited removal of the disease part. So that's why we call it functional, and it's endoscopically done, and it's sinus surgery. That's why it's called FES. So that is done for chronic sinusitis. Foreign body in the nose, ear, nose and throat, commonly found in A&E downstairs, also even in your general practice. They hardly come to medical wards because they always go through us. So ear foreign body is quite common in children because they tend to put things in there like beads and all, unanimated things, and grapes, seeds, nuts and so on. Sometimes they will get ticks in the ear or other insects in the ear. So try to remove ear foreign bodies if you are really skilled and if you have got correct instruments. Otherwise, I always send to us, because once a child is being frightened by trying to cause any pain, it's very difficult for us to come closer to the child and do any examination. Then we have to straight away take them to the theatre. So we would like them to be sent to us rather than trying, unless you are really do know what you are doing. Sometimes syringing might help. So we take you do the syringing and take the things like beads out, but if it's like a nut which can swell up because of water, we always try to take out these instruments. Very rarely we also have to take them to the theatre. Child is not cooperating, or if the foreign body is really deep inside where we can't reach. So ticks, when I talk about ticks, ticks are quite painful. And ticks there are usually tick seasons. They come in season. There are usually 2 seasons per year, and quite commonly found in Western province as well as in Sambara. Very painful. Live tick could be very painful. The saliva of the tick could be neurotoxic. It can cause middle ear, inner ear hearing loss as well as facial nerve problems. So if it is tick, we try to initially syringe out the tick to take out the tick feces. You see the blackish part. If you see any blackish sand-like part in any crying child, it could be a tick, because that blackish part is the feces of the tick, and the tick is really hiding behind all that. Right? And it really swells up. like it could be this color, it could be orange in color. So it could be any shade of any of those colors, and it's very painful. Light ticks could be very painful. So if the tick is right on the eardrum, we don't try to put instruments and take it out. We will damage the drum. So you always take it into the theatre and do under the microscope. But if the tick is not on the drum or maybe slightly lateral, we tend to give them sodium bicarbonate in glycerin eardrops and soften the fellows, the bugs, the insect particles, and then syringe it out, and it kills also when you put sodium bicarbonate, and it easily comes out. When the fellow is really killed and the child stops crying and the pain resolves, we know the fellow is dead. Then we can give them sodium bicarbonate eardrops and get them back to the clinic for surgery. Foreign bodies in the ears, again we have 24/7 service of foreign body removal in this hospital. So it's quite commonly found in toddlers and children. The number one thing that we have to remember is the danger of a button battery. Right? Very recently also we had a button battery, it had been there for few weeks, and even the doctors have, even professors have sometimes missed, and the parents bring the children because they have unilateral nasal discharge and bleeding. So by the time they come after about a week's time, the whole nose is all damaged. The end result of the button battery is inside the nose with the septum is damaged and there is a permanent hole on lateral wall. All the turbinates are all burnt, so you can have adhesions, and if the septal perforation is big enough, you can have a collapse of the nose and disfigurement. So we don't want that to happen. Any button battery in the nose or anywhere in the body has to be taken out as soon as possible, especially in the nose and also the upper airway digestive tract. But once it enters the stomach, it is coated with mucus and harm is very much less. So there is no dire emergency in that case. But if it is stuck in one place, it always causes erosion. So when I was talking about foreign body, I said we take the foreign bodies in the ward all the time, but in the foreign body, the nose is quite behind. We tend to take them to the theatre for general anesthetic because there is a theoretical possibility of aspirating the foreign body. Foreign body in the throat, number one is fishbone. In children, because the tonsils are huge, fishbones 99% of the time. In toddlers, the fish bones are stuck in the tonsils. So once the mouth is open, with lot of restrainment, we take the fish bones out in the ward. But if it has gone beyond that, we don't know it is. We don't know. We can't hardly see. There are these signs and symptoms of sharp foreign body. We do an X-ray. Sometimes X-ray is also not showing, but if history is suggestive, always take them to the theatre. So oral cavity fish bones or any other sharp foreign bodies, we can take it out with a long forceps and a good light. The child has to be there properly. Like in the first picture, you have to mummify the child, wrap with a bed sheet. If it has gone beyond that to the esophagus, like in this case, like in fish bone, they have to be taken out under general anesthetic. So again, fish and meat bones or even dry fish bones are quite common and quite could be nasty. They have to come out as soon as possible. Any sharp thing in the upper airway digestive tract cannot wait. They have to come back as soon as possible. But if you see something like this in this picture, now it is not just a simple coil. It's again a disc battery because you see double halo. You see a ring and inside the ring you see another halo. We call it double halo because on one side the usual coils don't have this side. The coil will have one single lining, but in disc batteries you have a double halo because it has got two things, one on top of the other. So that's why the double halo thing appears. So if you do a lateral picture, lateral X-ray, you will see step ladder like thing. So that's immediately a disc battery which we have to take out at even in the middle of the night. Last night also we had a case. The child came with a button battery stuck in the throat for nearly 8 hours. It was in the mid esophagus, which was taken out. So by the time it takes out, we see lot of destruction in the esophagus, lot of corrosion, sometimes it can really cause erosions and can enter into the mediastinum and mortal. So if there's a perforation in the esophagus, that's another way to manage. It could be quite serious for an esophagus rupture, cause mediastinitis. We don't want that to happen, so that's why we do it even in the middle of the night as soon as possible. We suspect just a simple coin can wait until the following morning, but not this. It has to come out. Foreign body aspiration we all the time get from the medical science also. Yesterday also we had a with a 1 week history of, there is no proper history of choking or anything like that, but the X-ray shows, just like in the first picture, X-ray shows they are trapping on the right lung. So there is lot of blackishness on that side, and the other side less, and the medial sternum is also shifted, which means on the right side the main process is blocked by some sort of foreign body. So these have to be, the foreign body is causing severe hypoxia, then they need to be taken out immediately even without fasting. But other cases can always wait until the morning, until our full team is available. So we do rigid bronchoscopy all the time for removal of the foreign bodies. The commonest thing what we get in children is peanuts. Right? Peanuts are no in children until they are 5 years old. We have to always tell the parent, because actually mechanism and their neural coordination is not enough for them to swallow a proper peanut. We have very good rapport with everybody in this hospital. So I'm very thankful to all of them for us to support we all continue our services. So I would like to thank, sorry I have taken some more time, I think my whole Sarah was about this extended time, and
we can spare a few minutes if you have any questions in ENT. Okay, in the absence of question, I am happy to invite Dr. Sukat Fernando, our Vice President of the Welfare Association, to hand over the program of the association. Last but not least, we would like to thank our sponsors, co-sponsors, BioLife Pharma and AI Insurance. And once again, I would like to thank you all for the presence actually from our 50 schedule. Yes, so BioLife Pharma and AI people who sponsor your refreshments. Thank you very much.